Well, good afternoon. For those of you on the West Coast, good evening. For those of you on the East Coast, my name is Flavio Roca. I'm from Oregon Health and Science University. And along with my co-moderator, Dr. Julie Halle from Sunnybrook in Toronto, we'd like to welcome you to the SSAT webinar on preoperative therapy for intrahepatic cholangiocarcinoma. I'd like to introduce first Dr. Mark Callery, who is the SSAT president and is also a professor of surgery at Harvard and chief of general surgery at the Beth Israel Deaconess. Dr. Callery.
Thank you, Flavio, and thank you, Julie, and everyone for making this extraordinary educational opportunity available. Based on what's happening with the SSAT webinar series, will be a huge number of people tonight. And so thanks a lot. And Stacy, hi. Thanks for being here. I have a few prepared comments I'd like to make, a little bit of my own, but mostly representing what the heartbeat of the SSAT says for you. Because tonight's a webinar. Tonight's about a tough disease. Nobody knows that more than you do. But it's about a celebration as well. Because it talks about the SSAT Public Service Award, originally founded in 2009. And we recognize an individual or an organization from the lay community that has impacted the public by promoting and creating awareness of GI health. You are this year's and last year's, given the pandemic, awardee of the SSAT Public Service Award, now given to the Cholangiocarcinoma Foundation. You've been instrumental in drawing so much needed attention to this disease, providing support, advocacy for patients, and bringing together scientists, investigators, clinicians, anybody to improve the outcomes for people who've had this disease and might. You support patients in several ways. You provide a database for HPB surgeons all around the country, America, probably Canada, who are experts in managing cholangiocarcinoma, therefore helping patients to locate the true experts and the healthcare centers they need. You host a very unique annual meeting where you bring together patients, clinicians, scientists, caregivers from all working sides of this disease, and you bring everyone together to learn together for 3 days. Amazing. You bring industry together with us in a non-biased manner in order to share ideas and devise great clinical trials based on breakthrough preclinical data. You offer international exchange of ideas, something I'll speak to in my address this year. So key, a pillar of success for the SSAT. You fund annual research grants to young investigators investigating cholangiocarcinoma. Stacy Lindsay, you are the president and CEO of the CCF, as we love to call it, but you represent so many more people. You do represent Mark Clements, your brother-in-law, your brother, excuse me, diagnosed in the 2000, who succumbed to this disease. You've advocated for him, and you've extensively researched treatment options, and you've begun networking worldwide so other patients can do better, and researchers and healthcare professionals can be best equipped. That's the motive of our webinar educational session tonight, to make everybody best equipped to know where they are. It's from your experience that the Cholangiocarcinoma Foundation was created. The SSAT recognizes that, but they also recognize you individually. The SSAT is extraordinarily proud and excited to confer its 2021 Public Service Award to you and the Cholangiocarcinoma Foundation and your entire team. Thank you so much for everything, and we welcome you to offer a few comments before we begin tonight's educational content. Thank you so much.
Thank you so much, Dr. Callery. That was so nice. We're so grateful. This has been my life's work, and it has been such a pleasure. And you work with a lot of the people that I work with, and so you know what a pleasure this is. This has been a true community collaboration. As advocates, we really can't move things forward without the clinicians, without industry partners and regulatory partners, without, it has to be done together. And especially in such a rare cancer as this, we have to move together. And I have just always found open arms at every turn, at every invitation. And it's just been an absolute pleasure. So thank you so much. We're so grateful for this award. We appreciate the acknowledgement, and we're so grateful to do anything that we can to further these efforts in any kind of collaboration that we can. So thank you so much. And I'm not sure how this came about, but thank you to everyone who helped us get here. We're really grateful.
Stacy, I'm entirely sure how this came about. Congratulations.
Thank you. Thanks so much.
Dr. Roca.
Great. I'll hand it over to my co-moderator, Dr. Hele.
Hi, thank you very much. And I'll take the privilege of this microphone to congratulate Stacy as well on this work and this award that is very much deserved. So for this webinar, we have an outstanding program about a very difficult disease to tackle, and hope we will learn a lot and have impactful discussions at the end. So we'll start by discussing preoperative treatment for patients with intrahepatic cholangiocarcinoma, followed by discussing the approach of surgery first, and then finally we'll conclude with a perspective from medical oncology. Through the talks and at the end, if you want to add questions, please type those into the Q&A, and we'll go through them at the end of the session with the guest speakers. So without further ado, we'll get started. And the first talk will be about preoperative treatment, improved surgery for intrahepatic cholangiocarcinoma. And our speaker will be Dr. Lally Maelstrom, who's a surgical oncologist and assistant professor of surgery at City of Hope.
Thank you. Thank you for the kind invitation to present at this forum. In the next 15 minutes, I'm going to convince you that preoperative treatment, where appropriate, will allow us to improve surgery for intrahepatic cholangiocarcinoma. In the past 10 years, what we have learned about this heterogeneous disease has evolved, and we as surgeons need to be forward-facing and harness the nuances of this disease biology and thus improve our outcomes. So let's get to it. First, we want to clarify that of the biliary cancers we are discussing today, it's really intrahepatic cholangiocarcinoma, not extrahepatic, not perihilar, not gallbladder, not distal bile duct cancer. Depending on the source, intrahepatic cholangiocarcinomas comprise approximately 20 to 40% of biliary tract cancers. They're incidentally identified in 20 to 30% of cases, and surgery is thought to be the only potential cure. However, the 5-year overall survival is only 30 to 40%, which means 60 to 70% of patients recur and succumb to this disease, which perhaps indicates that this is a systemic disease. Nearly a decade ago, the work of Tim Pollock and his colleague clarified for us that intrahepatic cholangiocarcinoma is associated with a worse prognosis when there are lymph node metastases, when there's an R1 resection, when there's vascular invasion, when the tumor size is large, and when there's multifocality. And when our scalpel fails, it's in the liver, it's in the peritoneum, and it's in the lungs where the recurrences occur. So if we are to say that this disease must be battled both at the local front and at distant sites, where do we stand in the context of systemic therapy? It was 10 years ago when the New England Journal of Medicine article came out enumerating the results of the ABC2 trial. This was a randomized controlled trial comparing gemcitabine with cisplatin in 162 patients to gemcitabine alone in 141 patients. The median progression-free survival was 8 months. The partial response rate was 26%. We were able to achieve disease control in 81% of patients, and the median overall survival was 11.7 months. Now that's where we've been sitting for about 10 years. And in 2019, Dr. Schroff, who's here with us today, published a phase 2 trial in 60 patients demonstrating a median progression-free survival of 11.8 months, a much improved partial response rate of 45%, and a disease control rate of 84%. Most importantly, the median overall survival in this study was 19.2 months. This is a giant step forward of 7 months from the ABC2 trial. Phase 3 data will tell us if this will be the new standard of care. However, at this moment, when this was published in 2019, it was a very exciting time for us. Well, what we must also consider in the context of systemic therapy for this disease is harnessing the rich mutational environment of biliary tract cancers. There are numerous targeted therapy options in this disease, and they span from oncogenic addiction with trials targeting FGFR, epigenome dysregulation, metabolic rearrangement, specifically mutations in IDH1 and 2, immune evasion in the form of checkpoint inhibition, microenvironment remodeling with the trial targeting VEGF receptors 1, 2, and 3, the ABC3 trial, and then targeting of Notch signaling, which would target developmental reactivation. I show you these mechanisms from an excellent review in hepatology this year, not for your memorization, but to demonstrate that there is not a single target that is all encompassing in this disease. In the Moscato 1 trial in 2017, this is a precision medicine study of the 34 included biliary tract cancers, 23 or 68% of them had actionable targets. That was much greater than the trial overall, which was 24%. And this led to numerous trials that included cholangiocarcinoma patients targeting aspects of the tumor microenvironment or the tumor epithelium. However, there are only a few that have made it to the phase 3 setting. No targeted therapy alone has given a response or disease control rate more efficaciously than chemotherapy. The exception would be that the Keynote 158 trial in MSI high patients had a 9% complete response and a 32% partial response. The limitation is that MSI high patients only make up a small proportion of intrahepatic cholangiocarcinoma. And here's an example of a targeting of IDH1 mutations, a randomized controlled trial, 124 versus 61 placebo patients. These were highly pretreated patients, but the progression-free survival improvement was only about 1.3 months. This clearly says we have a great deal of work to do. And what about the adjuvant setting? Where do we stand there? In 2017, the BILCAP data came out from the United Kingdom comparing capecitabine for 6 months versus observation in the adjuvant setting. And the results demonstrated overall survival of 52 versus 36 months. That for us is now the standard of care, 6 months adjuvant capecitabine in this population. During the same time frame, the PRODIGE 12 trial was occurring in France, comparing gemcitabine and oxaliplatin to observation. There was no differences noted in this trial in disease-free survival or overall survival. And that has led us to the ACTICA randomized controlled trial ongoing of gemcitabine and cisplatin versus capecitabine, and we are eagerly awaiting that, that study. So this gives us a framework of where we stand. Now, as surgeons, what about the initially unresectable patient? Can neoadjuvant therapy help us there? For the initially unresectable patient, do we give them palliative chemotherapy with gemcitabine and cisplatin? Do we add Abraxane now? Do we add immunotherapy? Do we add targeted therapy? I like to make the case for local regional therapy with Y90, systemic therapy with that, and then potentially surgery. Here's a case of a 63-year-old man, patient of mine with intrahepatic cholangiocarcinoma, who presented with some subtle sub-centimeter lung nodules and some lymphadenopathy. The tumor impinged on the right hepatic vein, and I was concerned about getting a negative margin with this resection. So we treated the patient with Y90 and 4 cycles of gemcitabine and cisplatin. Unfortunately, when we took the patient to the operating room for a diagnostic laparoscopy and resection, he had peritoneal disease, which is the case in up to 30% of patients. And so this was certainly not a victory for us, but he is now 18 months post-treatment, and his regional control is excellent, and he continues on systemic therapy. And the question is there evidence for this approach? And as of 2021, there is some evidence. Oncology from France, the MISFEC trial was published this year. The question was to determine the response rate after SIRT and chemotherapy in unresectable intrahepatic cholangiocarcinoma. So precisely the population we're discussing tonight here. The patients had 8 cycles of gemcitabine and cisplatin and radioembolization at cycle 1 and at 3 as needed based on the arterial anatomy. 41 patients were accrued to this trial, and the response rate, 39% by RECIST criteria of their target lesions, and 93% by CHOI criteria. CHOI criteria measures the Hounsfield units in the tumors themselves. The median progression-free survival was 14 months, and the median overall survival was 22 months. But from a surgeon's perspective, 9 out of 41 patients, or 22%, ultimately made it to the operating room. At 8 or 20%, 1 out of 5 achieved an R0 resection. At 46 months of follow-up, the median recurrence-free survival was not reached in the surgery population. In the top right here, I have the waterfall plot demonstrating maximal change of the best response for the target lesions by patient, and you can see everyone but 3 was below 0. And below that is the overall survival curve of 22 months median overall survival. The same group in 2020 published their data of 160 patients resected with intrahepatic cholangiocarcinoma. 32 of those were downstage preoperatively, 13 with chemotherapy and 19 with radioembolization. The median overall survival was 32 months, and most interestingly, the overall survival is no different between upfront surgery and those that were downstage. When they did their multivariate analysis, SIRT was associated with overall survival with a hazard ratio of 0.34. And in a discussion of this manuscript, they said, should this approach be considered for patients that are resectable up front? Not 100% sure we're there yet, but there are going to be patients that present that are technically resectable anatomically, however, physiologically they are not. This is a patient of mine who presented at 65 years old, 1 month after a CABG that had a complication resulting in a left lower extremity amputation. He was physiologically and mentally not quite ready for another operation, but his disease was certainly resectable. We treated him with radioembolization, gemcitabine and cisplatin for 4 cycles. And he had an excellent response and subsequently went on to resection. He remains NED at 2 years. So this is a tenable strategy, perhaps in this population where physiologically, perhaps they're not ready for surgery. I'd like to pivot a little bit here and talk about the role of checkpoint inhibition in intrahepatic cholangiocarcinoma. As noted previously, I said there are many trials. There are over 22 looking at immunotherapy in biliary tract cancers. Durvalumab, which is an anti-PD-L1, is going to be in phase 3 in a phase 3 setting with gemcitabine and cisplatin now, in addition to a host of others. It's important to note that there are 4 immune subtypes in intrahepatic cholangiocarcinomas. And the one I'd like to highlight is the immunogenic subtype, seen in 9 to 13% of patients. It is not quite clear which patients are going to respond outside of the MSI high setting in this disease. Is it a function of tumor mutation burden? Is it a function of PD-L1 expression? It remains a little bit unknown. This is a patient of mine, 68 years old. He presented with an intrahepatic cholangiocarcinoma with significant lymphadenopathy. He refused chemotherapy. And this is his pretreatment scan on the left and his pretreatment PET in the bottom left. His biopsy was a poorly differentiated carcinoma with a 90% tumor positivity for PD-L1. So this is back in 2018. We treated him with 4 cycles of pembrolizumab. He had a marked response and went to surgery. We were able to convince him to receive adjuvant capecitabine, and he was and remains NED as of March of this year. On his pathology report, his primary tumor had 70% necrosis. He had many lymph nodes that were consistent with neoadjuvant therapy and negative for viable metastatic carcinoma. So it will be interesting to see in the future how we select for patients for neoadjuvant immunotherapy. So in summary, neoadjuvant perioperative therapy is the future. Why? This is a systemic disease. To move the needle for survival, we need to treat the entirety of the patient. Remember, 30% 5-year survival. Neoadjuvant systemic therapy is not likely to result in disease progression. Remember, in the metastatic disease setting, 81 to 84% of patients are able to achieve disease control with systemic therapy. And in the unresectable local regional disease circumstance, SIRT plus gemcitabine and cisplatin is a tenable strategy. We have data now. The MISFEC trial, 22% became resectable. The future holds more tailored approaches that will likely complement rather than replace current chemotherapy. And frankly, the future is now. I looked in clinicaltrials.gov for neoadjuvant therapy in biliary adenocarcinomas. There were not a ton in the United States, many in China, Italy, Thailand, Korea, but there were a few. One of them notably was in my debate partners institution, the University of Cincinnati. I just thought you all would want to take note. And then the other is gemcitabine, cisplatin, and Abraxane in patients that are high risk, that is being led by Shisher Meitel. And those patients include T-stage greater than 1B, solitary lesions greater than 5 centimeters, multifocality, vascular invasion, and nodal involvement. So thank you very much for your attention, and I look forward to the remainder of the program.
All right, so we'll go ahead with our next speaker. My apologies, I'm not able to restart my video, but our next speaker will be talking to us about surgery-first strategy should be considered for most patients with intrahepatic cholangiocarcinoma. And this will be done by Dr. Shimul Shah, who's a professor of surgery and HPB surgeon and transplant surgeon at the University of Cincinnati.
Thank you, Dr. Halle. So we're going to talk today about a surgery-first strategy and why we should consider that for most patients with intrahepatic cholangiocarcinoma. For disclosures, I don't have any relevant financial disclosures, but I will say that I am a surgeon, and let's talk about operating. I'm going to be debating my partner, Dr. Melstrom, who is a rising star in surgical oncology, well known, and here I am, I'm just a transplant surgeon. So take it easy on me, guys. So we've already seen and heard a little bit about cholangiocarcinoma. I think there's 2 important things that we need to know about. One, we have a very low incidence of intrahepatic cholangiocarcinoma and it primarily occurs in older people. You see the different types outlined here. And as you can see, for all cholangiocarcinomas, only about 10% are going to be intrahepatic. So we're dealing with a rare tumor, and that gets to one of my points in a little bit. Here's our staging, and the staging is based on invasion and number and not size, as we all know. And we break it down. The lymph nodes become very important in determining the importance of staging as it constantly changes. So why do we recommend resection first? It's pretty easy. We want to do a hepatectomy with negative margins. The consensus in general currently today is for a surgery first approach. Whether you do parenchymal sparing or you do anatomical resections, for the sake of this talk, I don't think it really matters. We need negative margins. We also should be doing a portal lymph node dissection for a few reasons. One, we need to determine staging because of its importance. It determines prognosis. In the past, we would say if it's positive, they would get chemotherapy. I don't know if that's necessarily true anymore because everyone gets chemotherapy. And we know that nodal disease is really important. You get 30.1 months versus 22.9 months in terms of overall median survival. Layla, she mentioned Tim's paper looking at 450 patients with intrahepatic cholangiocarcinoma. We know that most of them are solitary, they're large lesions, and the median survival isn't great, 27 months with a 5-year survival of 30%. So that's where we are with the surgery first approach. There've been a few retrospective studies, and you can see the R0 resection rate is not super high in some studies. A lot of patients have positive nodes, but the recurrence rate is really high, whether it's intrahepatic or whether it's distant, and these are all retrospective studies. So let's go through the reasons of why we don't want to pursue neoadjuvant therapy first. Number one, we don't have any level 1 evidence. We have 2 retrospective studies essentially that talks about neoadjuvant therapy. The Leroy study was essentially in unresectable tumors, as Dr. Maelstrom was talking about. And after they became resectable, they had similar short and long-term results. Same thing in this paper from Annals of Surgical Oncology from last year, downstaging with radioembolization and chemotherapy. Only 32 out of 169 underwent downstaging, no difference in survival once you got them downstaged. So certainly promising results, but that's basically all we have currently for neoadjuvant therapy, 2 retrospective studies. What's the second reason? Well, we're dealing with an aggressive biology, and that becomes really hard for multiple reasons. First of all, it becomes very frustrating. As you look at the data here for median survival on the left-hand side based on stage, the survival is dismal. And when you break it down, after you get to stage 2, 3A, 3B, we're dealing with survival 25% and less. And when you look at the patient cohorts that are in this SEER analysis, essentially very few patients are T1 or even T2 disease. Most patients are metastatic, T4, and a small portion being T3. So this is a frustrating disease. It becomes very difficult to enroll patients in neoadjuvant trials and get them enrolled in all kinds of trials, but primarily in a non-surgical first mentality. We have really modest and minimal efficacy with the current chemotherapy. We talked about the ABC trial already, and as you heard, we did have some improvement in median survival from 11 months to 8 months, 3 months. It isn't a whole lot, and a progression-free survival from 8 to 5 months. This was a negative intention to treat trial. We heard about Dr. Schroff's study as well. It's a 2-center study with 62 patients, single-armed. It's a phase 2 trial in advanced biliary tract tumors. And again, progression-free survival, 11.8 months, certainly commendable with a 19.2 months overall survival and a 40 to 50% response rate. But this was not level 1 evidence, and more work needs to be done in this area. Another reason, adjuvant therapy works. We have 3 major trials. The last one is really for extrahepatic cholangiocarcinoma, but we have the BILCAP trial, which you heard about. And to quickly go through that, we had a randomized trial of capecitabine for 8 cycles after surgery in a 1-to-1 randomization, a well-done study. And the one issue with it, though, was only 19% of the patients had intrahepatic cholangiocarcinoma in the trial, 84 total. And so we need to take that data with a grain of salt, but we did see an improvement in median overall survival with CAP versus observation and recurrence-free survival as well. Leading to the recommendation, that we should give capecitabine for 6 months after surgical resection. When we talk about the PRODIGE study, we did not see a difference in relapse-free survival and overall survival, but certainly the trial was well done in a randomized fashion. We have many ongoing randomized control trials currently for adjuvant chemotherapy. None that are listed here are in the US, primarily in Europe and in the Far East, looking at all different regimens to be given after resection. We're looking forward to seeing how the results are going to play out around the world. So there's a lot of promise in the adjuvant setting. Finally, as I mentioned earlier, there's difficult enrollment in neoadjuvant trials. And we have one currently, a phase 2 GEM-CIS nab-paclitaxel trial that is underway, but we need to define the role of immunotherapy and whether it should be given pre or post resection. We heard about immunotherapy already, and there's many options and many opportunities to use immunotherapy in in biliary tumors, but we have a few issues. One, they're not primarily covered by many insurance payers and companies. And secondly, there's really no standard recommendations of who should get profiled and who shouldn't. Certainly at our center, everyone's getting profiled, but I don't think that's that's common at most places, especially in smaller centers and community areas. When we talk about next generation sequencing and clinical management, we certainly have many genetic alterations. I apologize for the dog. Many genetic alterations, but one of the problems is that it actually occurs in very few patients. Only 16% and 11% for our two most commonly approved genetic alterations. So let's review a case and why this makes sense. This is a patient that in 2014 presented with a coloducal cyst. I performed a Roux-en-Y hepatocogenostomy. She actually presented with a 4-centimeter mass in the left lobe 4 years later, which was proven to be cholangiocarcinoma. Here's her scan. You can see a nasty tumor in the left lobe. So we performed a resection first approach in 2018 and did an extended left hepatectomy and a portal lymphadenectomy. Found a 6-centimeter polydifferentiated tumor with mucin, had 2 out of 6 positive lymph nodes, and a positive resection margin. Certainly a very negative path report. We did adjuvant therapy. We did some profiling. She certainly had MSI high tumors, and so certainly a favorable molecular biology profile. She underwent GEM-CIS for about 5 months in 2019, followed by some chemoradiation to the positive margins. And then for the last 2 years, essentially been on pembrolizumab and has received 20 cycles. We just saw her in follow-up to see if there's anything else to do, and her PET scan and her CT abdomen were showing no evidence of disease. And she's doing very well. So just an example of a surgery first approach with negative biology, but doing well now 3 years after resection. So in summary, surgery first strategy is the current standard of care. Adjuvant therapy does work, at least in the randomized setting. We need more studies and collaboration for a neoadjuvant approach, but it's difficult with rare tumors. It's difficult to do due to aggressive biology. And I know we've done a lot of work in pancreatic cancer, but this tumor is even more rare than that. It makes it very difficult to enroll and to get nice studies done with appropriate intention to treat power and analysis. And therefore, we've struggled in this regard from the neoadjuvant setting. We do have promise with immunotherapy, and we're very excited to see what Dr. Schroff has to say in regards to this, but we need to understand how best to use it, whether it's in the pre-resection setting or in the post-resection setting. Thank you very much for your time.
Well, thank you very much, Dr. Shaw. We've now heard 2 excellent talks from surgeons, and now we're very eager to hear the perspective of our invited guest, Dr. Rachna Schroff, which it's my distinct pleasure to introduce. Dr. Schroff is an associate professor of medicine and the chief of the section of GI medical oncology at the University of Arizona Cancer Center. She's also been recently appointed the associate dean for clinical and translational research. So we are extremely pleased that she's here with us today. Dr. Schroff, please take it away.
Thank you so much. And thank you all for the invitation to participate. I was telling Flavia that I feel cooler and hipper being involved in a surgical meeting. You guys are such a power team, and I love the fact that you are interested in hearing the medical oncology perspective on this. I think, in all fairness, my number one disclosure is I don't think there is an answer yet, but that doesn't necessarily mean that we shouldn't be asking the questions. So these are my disclosures. And, you know, obviously we know that biliary cancers is a very heterogeneous group of diseases, and intrahepatic cholangiomas in particular, we've already kind of heard how they are distinct and should be treated differently than extrahepatic cholangiomas and gallbladder cancer. But I think what we also know is that surgery alone, when it comes to intrahepatic cholangiocarcinoma, is not enough. It is our curative treatment, and we've already kind of talked about this paper with 449 patients that looked at the 5-year overall survival. And I think we can all agree that we need to be able to do better. So this is where we're at in terms of the current perioperative approach. The BILCAP trial, as we all know, looked at 6 months of capecitabine versus observation after resection of biliary tract cancers, and included intrahepatic cholangiomas, but also had extrahepatics and gallbladder cancers. And the median OS was improved with capecitabine. It was numerically improved. The hazard ratio was 0.81, but there was a pre-specified protocol analysis that when adjusting for specific factors, the hazard ratio became 0.7 with the p-value of 0.007. So we became comfortable with the concept of utilizing capecitabine in the adjuvant setting, thinking at least numerically when, you know, a number of people feel statistically significantly capecitabine improves overall survival. So then, of course, you know, in the pancreas world, in the colon world, what works in the metastatic space or in the adjuvant space, should we start to think about it in the neoadjuvant space? But then, of course, when you're thinking about neoadjuvant therapy, you're thinking about the important questions that have already been discussed. So will it downstage? What is the utility of neoadjuvant therapy? Does this help us understand biology? And beyond capecitabine, which, yes, is a good drug, what else could work? And I think that's really where a lot of the interest lies. Is sure, we could look at capecitabine in the neoadjuvant setting, but we know a lot more about biliary cancers now. And as has already been mentioned, we've had a number of studies that have looked at adjuvant therapies in biliary cancers with BILCAP, PRODIGE, BCAT, JCOG, and ACTICA, all being things that have already been discussed. Now, ACTICA is obviously ongoing, and I think is probably of great interest to everybody, as has already been suggested, given that this is looking at GEM-CIS, originally compared to best supportive care, or rather observation, but now has been changed to the control arm being capecitabine. And as it stands today, capecitabine is our standard of care. Resect, and then 6 months of postoperative capecitabine, at least according to ASCO guidelines and NCCN guidelines. So then, of course, we start to think about what we're doing in the advanced stage. And as we know, it has been 10 long years of this being the king, GEM-CIS, with the median survival of 11.7, and has already been mentioned, you know, numerically an improvement in about 3 months with the addition of cisplatin in the metastatic setting for biliary tract malignancies, but statistically significant. And as I tell my patients, tried and true. We know how to give it. We know what to expect from it. We know it can work. The response rate with GEM-CIS is about 26%, at least when you look at the ABC02 study, which included intrahepatics, but obviously, of course, included all biliary tract malignancies. Now, this study has been referred to already, but the phase 2 trial of GEM-CIS nab-paclitaxel is really kind of what I think pivoted the conversation around neoadjuvant therapy. So this was a study of a planned initially 50 patients, subsequently became 60 patients who were newly diagnosed cholangiocarcinomas and gallbladder cancers. This was done at MD Anderson Cancer Center in Mayo, Arizona, with the triplet regimen, GEM-CIS with the addition of nab-paclitaxel. With the addition of nab-paclitaxel, not surprisingly, there was a fair amount of myelosuppression and hematologic toxicities. And so we dose adjusted the GEM and the nab-paclitaxel and decided to do a total of 60 patients instead of 50 to really get a better sense of the quote unquote newer dosing schedule. In this study, the primary endpoint was progression-free survival, but we did look at secondary endpoints such as overall response rate. And as you can see here, this was a predominantly intrahepatic patient population. 63% of patients were intrahepatic, which is a little bit different than, say, the ABCO2 study. So probably more reflective of the changing and shifting epidemiologies that we're seeing in biliary tract malignancies. And importantly, 78% of patients were metastatic, 22% locally advanced. And as has already been mentioned, the primary endpoints of median progression-free survival was striking. It was 11.8 months. And while you should not compare things to historical controls, just as a reminder, median progression-free survival of GemCis is 8 months. Median overall survival was 19.2 months, which again, comparison, 11.7 months of GemCis. But what I think also jumped out at us was the 45% overall response rate, and the 12 of 60 patients who were converted. Now, these were patients who were discussed at multidisciplinary tumor boards at Mayo and at MD Anderson and were told they were unresectable. And 20% of these patients were converted from an unresectable situation to a resectable disease and taken for a curative operation. Initially, at the time of publication, 2 of 12 had a pathologic complete response. We subsequently actually had 3 patients with a pathologic complete response. And this is just an example of a patient who had a response radiographically, but also had a path CR after GAP. But what was interesting, and we actually saw this on a couple patients, and this speaks to my frustration sometimes with using RECIST as a hard and fast criteria for clinical trial design. But there were some patients who had radiologic stable disease who actually had really dramatic responses pathologically, including pathologic complete responses, but patients who ended up with 10%, 20% viable tumor or a complete response. This was the waterfall plot, just suggesting that most patients had some sort of benefit to the triplet regimen, and that's what has led to the ongoing phase 3, ongoing in the sense of we're awaiting final analyses, but this has completed accrual, and this is the randomized study in the phase 3 setting for newly diagnosed advanced biliary tract cancers, comparing the triplet to GemCis, because I will acknowledge, like Dr. Shah said, there's not level 1 evidence yet for the triplet. And so we really want to know if this is better than GemCis. And at the end of the day, what I always argue is that GemCis, the data that we have for GemCis is from 2010. And there's not a doubt in my mind, I would imagine, that the GemCis arm's median OS is actually going to be better in SWOG 1815 than it probably was in ABCO2. So it will be really important for this study to give us a true answer about triplet versus doublet, but also really just kind of set the new bar in the metastatic world for what outcomes look like with chemotherapy. So then we've heard about NeoGAP. That's what I think I lovingly coined it. Maybe Shishir did, but this is the study that has already been alluded to. This is looking at the feasibility. That's really an important question, I think, in the neoadjuvant space. Feasibility of neoadjuvant therapy with the triplet in patients with what is defined as resectable but high-risk intrahepatic cholangiocarcinoma. And the questions are, will it increase resectability? Will it improve recurrence-free survival, overall survival? It's a planned 30 patients, and I actually have not gotten a recent update from Dr. Maithal, so this might be more than 23. But I would actually argue with Dr. Shah that I think this is accruing, and I think demonstrating that we can do a neoadjuvant study. And this is just the definitions, has already been mentioned, but this is the definition of what was called high risk, quote unquote, but resectable intrahepatic. Some of what we know are kind of poor prognostic features. So let's talk about what I think is where a lot of interest lies. And we know that one size doesn't fit all for biliary cancers. Clinically heterogeneous, varying etiologies, differing presentations and complexities, but this is really where the money lies. And over time, what we have learned is that intrahepatic cholangios in particular are target rich between FGFR2 fusions, IDH mutations, and then a smattering of rare but very relevant and targetable alterations like BRAF mutations. And so again, I would argue that while maybe the uptick is slower in terms of the role of molecular profiling should be 100% standard of care for our cholangiocarcinoma patients. 40% of intrahepatic cholangiocarcinomas have targetable alterations. If we are not looking for them, we are not doing service to these patients. So this is an example of why this is relevant, why molecular profiling is relevant. This is the CLARITY study. This is a randomized phase 3 study looking at ivosidenib, which is an oral IDH1 inhibitor in patients with known IDH1 mutations who have had at least 1 or 2 prior lines of therapy. This study the final data was presented at GI ASCO this year. This is the PFS. This PFS data was read out back at ESMO in pre-COVID, whatever year that was, 2019. And the PFS was a statistically significant improvement with ivosidenib compared to placebo. My argument has always been, while numerically not amazing, look at the way the curves separate. And I think that's really where the money is the patients that end up benefiting from ivo really benefit. But importantly here, only a 2% partial response rate. Contrast that with one of many FGFR inhibitors that we now have, but this is the data presented by Dr. Javle this year. This is the final data on infigratinib, which is an oral FGFR inhibitor, looking at patients with FGFR2 gene fusions. Primary endpoint here was objective response rate, which was 23.1% in 108 patients who had known FGFR2 fusions and who were quite refractory to therapy. So when you look, when you break it down, 50 of the patients who had kind of earlier infigratinib earlier in their lines of therapy actually had a response rate of 34%. So suggesting that the more we shift up targeted therapy, perhaps we get better responses when it comes to FGFR inhibitors. So using it in the second line versus the third or fourth line. And median progression-free survival in this very refractory patient population was 7.3 months. Just a reminder, retrospective median PFS in second and third line therapies is 2 to 3 months. ABC06, which is now the new standard of care in the second line setting, FOLFOX, median PFS is around 4 months. So this was really striking. Importantly, and this is the waterfall plot for infigratinib, and importantly, this drug has been accepted. The new drug application for infigratinib has been accepted by the FDA, and we are awaiting, I think, any day now, hearing about the FDA approval of this drug. And then we add in pemigatinib. Pemigatinib is already FDA approved. Pemigatinib was the quote unquote first to the FDA. This was the FIGHT 202 data. Again, overall response rate was right around 35%. These were primarily earlier treated patients. And so, of course, I think that begs the question, should targeted therapies play a role in perioperative therapy? And what do we do with more cytostatic drugs like ivo? Ivo is essentially a lot of stable disease. So when we think about neoadjuvant therapy, I think the question should be, how can we integrate molecular testing targeted therapy into the neoadjuvant setting for resectable disease? And myself and a number of people on this call have the privilege of working with the ICRN, the International Cholangiocarcinoma Research Network. A perioperative working group has been formed to really look at incorporating targeted therapies into the resectable population. And I think the general sense of the group is, let's focus on what we can do. Intrahepatic cholangiocarcinoma seems like low-hanging fruit. Hilar and distal cholangios are harder to get pre-op tissue diagnosis. The access to tissue for intrahepatics are easier. Patients seem to be able to tolerate preoperative therapy, and it is the subset of biliary cancers that has the highest percentage of targetable mutations with a reasonable response rate. So FGFR2 fusions, we think, are present in about 25% of resectable disease. That's what some of our retrospective data suggests. But the real question is do we know? Do we really know what the FGFR2 fusion prevalence rate is in resectable intrahepatic cholangios? And what about the logistics? Can we get these patients profiled in real time to get the answers and integrate it into our treatment algorithms in an efficient manner so that we're not keeping people who have potentially curable disease from the OR? And so, this study is just one example, I think, and hope, of studies that will hopefully answer this question. This is a study that Dr. Maithal and I have been working on. This was a beautiful slide made by Dr. Maithal that summarizes the OPTIC study. He's really good at names. So this is the OPTIC study, which is looking at resectable intrahepatic cholangiocarcinoma patients. Patients who are resectable get a cycle of GAP, as I lovingly call the triplet, while we're profiling, and those who are FGFR2 fusion positive then go on to FGFR inhibitor versus those who are negative continue with GAP. And this is, again, a feasibility question. We're not looking for 75 patients and powering for response. This is a question looking at, high volumes, very skilled centers, and asking the question of, can we get these answers in real time and can we integrate them into treatments? So when I think about where we go next, I think there's clearly a role for profiling all cholangiocarcinoma patients. And as we get more neoadjuvant studies open, I think that role for profiling should be happening earlier and earlier in their treatment journey. And I think basket trials will help us try to capture multiple targets. So I love this because the plan back in the day was for in the advanced biliary tract cancer setting, this beautiful plan, this beautiful multi-basket study called BATCH. And BATCH was going to look at a number of different baskets with a number of different molecular alterations with profiling, and you put people into a basket. That plan is kind of on hold, or is evolving, I guess. But as I have said before to Drs. Roca and Maithal, so if it is BATCH for advanced disease, what about neobatch? Periadjuvant, should we be doing periadjuvant basket studies, looking at resectable populations with profiling, and we give them GAP or GemCis or whatever it is while we get the profiling, and then we create these baskets and we try to ask these questions of immunotherapy, FGFR inhibitors, IDH inhibitors, et cetera, because I really think that's going to be the direction that we have to move in to be able to answer these questions, before my grandkids have grandkids. So in terms of future directions, I think we eagerly await the results from the ICRN neoadjuvant study so that we can understand the role of chemointensification in the perioperative space. And I think if one size doesn't fit all, which we can all agree on, should the different approaches be based only on anatomical differences, or should we start to base them on molecular profile and let things like prognostic impact, response rates, et cetera, affect decisions? And should we take more of a periadjuvant approach? My answer for everybody today is we don't know. But I also think that if we don't ever ask the questions, we'll never know. And so in the words of my daughter's favorite musical, I really think history has its eyes on us right now. And I think thinking through these in very smart clinical trial designs is going to be the way for us to charge forward. Thank you very much.
Well, thank you, Dr. Schroff. That was, as expected, a wonderful tour of the landscape of biliary cancer. And again, we're happy to have you here along with our panel. So if our panel can kind of turn on their cameras, looks like they're all on, and get themselves unmuted, we can start answering some of the questions that were posted in the Q&A and the chat. So I don't know, Dr. Halle, do you want to take the first couple?
Yeah, I think we can get started with sort of how do we define the patients who would potentially benefit from neoadjuvant therapy for intrahepatic cholangiocarcinomas. There's a few questions, I guess, with regard to how do we define patients who are locally advanced or deemed unresectable, and whether there's any heterogeneity in that aspect at the moment.
So Dr. Mellstrom did talk about a trial that we have opened at our place. Obviously, it's just a single center. It's really just more of a feasibility trial, but we decided to start it in just resectable tumors. So hilar tumors and intrahepatic cholangios, we would do neoadjuvant chemoradiation, GemCis and SBRT, depending on the location and everything else. So again, we have a lot of experience with chemoradiation to the hilum in transplantation for hilar cholangiocarcinoma, but we started out with just purely resectable tumors, and we just opened it. It's just been opened a few months ago, so we've only enrolled a couple patients, but that's our intent as just a single center study. And I think that's the way to start it, because as you saw in the questions, there is some concern about what's resectable, what's not. It gets a little hazy depending on surgeon to surgeon.
I think what you brought up, Shimel, is something that we struggle with between surgeons and oncologists, right? So there's the technically resectable but oncologically high-risk lesion. And this is what our trial was initially going after, which is you have that patient with let's say the dominant large 5-centimeter lesion, which, as Dr. Pollack points out, that's now split up into the T1B lesion that may have satellites, all right, or they may have periportal adenopathy. All those things are resectable, but that patient's going to be at high risk for recurrence. And so I think of it as more of, can we identify that population similar to, let's say, the borderline resectable pancreas cancer, and use that paradigm as patients that should potentially be considered for neoadjuvant therapy?
A definition could be biologically borderline resectable versus technically borderline resectable. And biologically borderline would entail patients with lymph node metastases or presumed lymph node metastases, larger tumors, multifocality, vascular invasion, all of the criteria that are included in the Shisher-Meitel trial that's currently accruing.
We had Dr. Schroff, any comments on that?
No, I totally agree.
We did have a question perhaps for you from Dr. Callery about the molecular profiling. You know, should this be sort of a routine blood test? You know, what are the sort of limitations or barriers? Even Dr. Shaw hinted at that. Perhaps the academic centers are doing it, but how do we get that message out to the community?
Yeah, I think that's a great question. You know, their next generation sequencing platforms are really the best way to approach this, because that way you get comprehensive profiling done. Because, you know, FGFR2 fusions, for instance, are only 10 to 15%, but IDH mutations are about 20%. And then you've got that smattering of BRAFs of 3 to 5%, and the rare needle in a haystack of the MSI highs. And so NGS, I think, is the best way to go. Tissue for intrahepatic cholangiocarcinomas, usually we have tissue, and tissue-based NGS is really my preference. And myself and a couple other medical oncologists have gotten into heated debates, because I have yet to believe that the ctDNA-based platforms are nearly as sensitive for FGFR2 fusions. We just do not have data that says that they can identify all of the FGFR2 fusions. These are the blood-based, the liquid-based platforms, that they can identify all of the FGFR2 fusions in the same way that whole transcriptome, RNA-seq, you know, the methodologies that are used in tissue-based next-generation sequencing. So my first gut is to try for tissue, especially with an intrahepatic. And sometimes I'm even willing to put them through another biopsy to try to go with tissue. And then if not, then I reflex basically to liquid-based ctDNA platforms. What we know for FGFR inhibitors is that they are partner agnostic. So the FGFR2 fusion, all you need is the FGFR2 gene. It can be fused to a myriad of different partners. And when you look at the infigratinib, pemigatinib data, there's 50 to 60 different partners that have been identified. So you don't want to miss it. And that's why I think it's really important to use tissue.
Dr. Shaw, we also have a few questions in the Q&A regarding the role of liver transplant for intrahepatic cholangiocarcinoma. So whether there is a role at all, and if neoadjuvant is not that effective, then why is it mandated prior to going ahead with liver transplant for intrahepatic cholangiocarcinoma?
So we don't have any accepted indication to transplant intrahepatic cholangiocarcinomas, at least in the US. Are we doing it? Yes, we are doing it. We're doing it in small, unresectable tumors, usually in cirrhotic livers, but we don't get MELD exception points or anything like that. So centers that are doing it, it's rare and far and few between. And we just recently did publish a collection of many sites, and it was more for mixed intrahepatic and HCC tumors. But there really isn't any consensus about whether it's indicated, it should be done. I think there's going to be a role in the future to do this. We are currently writing a protocol for this as well. And we have transplanted a couple, again, small tumors, favorable biology. And we did one patient that was on immunotherapy for about a year and was unresectable initially, remained kind of stable. We transplanted him 2 Christmases ago, and he had no tumor in the liver. So I think that's the future for us, and it could be potentially a future for patients that get downstaged with liver-only disease, with immunotherapy, with any regimen for that matter. If they're still unresectable, is transplant going to be an option? Maybe with a live donor or something, it could be.
Do you have a sense of how many centers are doing protocols? We obviously, you know, the ones I'm most familiar with is the protocol that Houston Methodist did with MD Anderson.
Right.
And I think that was, at least at the time of the publication, there were 21 enrolled patients, 6 that eventually got transplanted. But I know that transplant oncology seems to be really kind of a growing field, not just in this disease, but in others. So, I mean, with this advent of profiling and targeted therapy? Does that make it any easier?
It's a complete guess, but I would say there's probably about 10 centers. Methodist, UCLA is the one that started it out. The problem with immunotherapy is we are extremely scared to transplant those patients because you have two differing biologies going on. You're stimulating it like crazy, and then you're suppressing it after the transplant. And there've been some reports of graft failures very early on and other issues. So we are starting to study this in HCC, whether it's feasible, whether it's safe. The drug companies, and I have no disclosures, but the drug companies are very scared about transplantation in these patients. So it's going to be a hard one to get passed through. And we are scared as well, just because we're not sure what the future holds. We have done 3 patients that were on immunotherapy, and all 3 have done well. But there's case reports of many patients that have not done well.
The only other thing that I would say is when you look at Lunsford at our paper on the Anderson and Methodist group, interestingly, to your point, Shamal, that there was out of the, I thought it was more than 6, Flav. I think it was maybe maybe 10 or something, but about 5 to 6 of them actually had alterations that, to me, justified the biology that led to the availability led to the timeline that would allow for a transplant. So my couple patients that I sent for transplant were FGFR2 fusion, and I had a BRAF. And so these were people, and this was pre-targeted therapy. It's not like I had an FGFR inhibitor that I had them on. It was more just, we know that FGFR2 fusion patients seem to have a little bit more of an indolent course, a little bit better biology. And to your point about noticing that stability of disease and that as kind of an indicator of biology and weeding out the people who probably should not be considered for this, I think that's probably playing a role, I would imagine.
Waiting a year makes a lot of sense to me.
That sounds like a very similar argument that we have in pancreas cancer. A couple questions here that I'm seeing here about what's an acceptable threshold for a treatment response to consider neoadjuvant therapy? I think you had mentioned about the cytostatic drugs versus the cytotoxic. And so what's a reasonable expectation to treat somebody prior to therapy? And then on the flip side, while I have you, is what do we think about adjuvant targeted therapy?
Yeah, I mean, I think the cytostatic versus cytotoxic probably matters more in the neoadjuvant space. I think there's a lot of interest, actually, for instance, looking at IDH in the adjuvant setting. The concept of if you're inhibiting and putting a brake on what we know are oncogenic drivers, and you have completely resected the disease by giving IDH inhibition or FGFR inhibition, you could be, in theory, I mean, scientifically, it makes sense that you could be decreasing recurrence rate, right? Improving recurrence-free survival. So I think in the adjuvant setting, that kind of cytostatic drug could be considered just as much. I think, the question of neoadjuvant, it's a question of whether or not you're asking the question of biology to all of your points. Are we using neoadjuvant therapy like in the panc world, that we're weeding out the people that should not be going to surgery, and we're understanding through the test of time what these patients need, versus downstaging, right? I mean, I think downstaging, or somebody who's oncologically high risk with those poor prognostic players, like you mentioned, there, I think an FGFR inhibitor where you have that response rate of 20 to 30%, that really does matter, right? Because you're not taking these people to the OR. You want to be able to maintain at least disease control, if not some sort of response. But if it's really more just the question of, are these patients bad players, then I don't know that there's really a hard and fast cutoff. I mean, the short answer is I don't think we know. But at the end of the day, GEM-CIS response rate in the adjuvant, in the metastatic setting is only 25%. I mean, we're not talking lymphoma response rates with our disease, with our drugs.
Right,
Dr. Maelstrom?
Yeah, I have a question for Dr. Schroff from a systematic disease perspective. Beyond gemcitabine, cisplatin, or gemcitabine, cis-Abraxane, how do you decide if you treat a patient with immunotherapy that's not MSI high?
Yeah, I'm a little bit of a skeptic when it comes to immunotherapy. Flavio's heard me say this. So, MSI high, TMB high is a, tumor agnostic approval. My problem with TMB high is what does TMB high mean in cholangio? I don't think it means the same thing as TMB high in melanoma and lung cancer and these more immunogenic and hot tumors. So I think it's a question. My general answer is, if there's, I don't use it until I feel, if there's no obvious marker, if there's no MSI high, there's no TMB high, there's no, PDL1, 100% positivity, or I don't know, something like that, then I don't necessarily use it, or I use it in the setting of a trial. But beyond that, I'm really kind of underwhelmed. I'm definitely underwhelmed by single agent. Even the NIVO, the multi-center nivolumab study, 22% response rate, but on central review, like that was investigator assessed. When you look at central review, it was 11%. And the Keynote 158 data was really kind of depressing. I'm excited for Gemcis Durva, don't get me wrong. And I'm excited for Gemcis Pembro and Gemcis Nivo and all these other Gemcis Plus studies. But even like bintrafusp alpha, which we were all really excited about, so far the data that's come out, that's the TGF plus PD-1 bispecific. And even that has been, so far from the limited data we've seen, is a little bit underwhelming. So I don't know that we've figured out the switch yet to turn what is a relatively cold tumor hot.
Right, and maybe now circling back to the surgical decision-making and the surgical management itself. Would you all consider that if somebody has multifocal disease or suspicious nodal disease on preoperative workup, that those patients should be deemed unresectable, or should they go ahead with surgery?
Well, I would say, again, that falls in that biologically high risk category. And I think we also had a question in the chat about whether these patients should undergo some kind of diagnostic laparoscopy. And I think this audience has knows my personal biases on that. I mean, I think any patient starting any kind of neoadjuvant therapy should have a laparoscopy to complete their staging. So I'd say, no, they're not unresectable, but again, I would favor some kind of pre-op therapy for those patients after complete staging.
And again, very similar debates to what we're having right now for pancreas cancer. Dr. Maelstrom, any additional thoughts on this?
I mean, the thing you have to remember is that you're not expecting a dramatic response in the tumor size or perhaps the echogenicity. With a 26% response rate with gemcitabine and cisplatin, do not expect any miracles with your neoadjuvant therapy. Expect stable disease. Maybe with gemcitabine, cisplatin, and Abraxane, you'll get a 45% response rate, and it'll reflect itself in overall survival. But really, don't expect any miracles. And also, the likelihood of progression during that time, the counterpoint would be that the likelihood of progression during that neoadjuvant period is very low. You would expect stable disease. That would be your expectation. So are you better off with neoadjuvant therapy? I don't think we know the answer to that yet. And I don't think you could prescribe that to all comers, even though that was my position in the debate.
Yeah, I think the positive nodes is, I mean, been there a lot, and it's really tricky. You can get in the US and confirm it's cancer, even if the PET scan's not positive. What do you do? I think we tend to give neoadjuvant therapy in those patients for exactly all the reasons that Dr. Maelstrom was talking about. And at least if they're stable, then maybe you feel more justified to go in and resect it down the road. But that's a tough one that I think we all encounter a lot.
Speaking to that though, Shimel, there's not portal lymphadenectomy, although it's been now shown over and over again to be, as you said, prognostic and is not performed widely. I mean, do you think that still needs some more education, or how do we get our surgical colleagues to buy into that?
I think, didn't Dr. Maelstrom write a paper on this saying that lymph nodes aren't necessary?
No, not me.
No, wasn't you?
Wasn't
okay.
me.
A lot of surgeons don't believe that it's necessary because everyone's going to get capecitabine post-op. But I couldn't disagree more. I think you should take them out and at least have some sense, just like we talked about on the staging and how poorly they do long-term. At least it allows you some prognosis. So I do it every case, but you're right. I think only about half the surgeons in this country do it, at least based on some SEER data and other data that we've looked at. I'm puzzled. but I know many surgeons that don't believe in it.
I don't think it's a religion. I mean, I think it's education. I don't think it's a belief issue. I think they just need to education. I mean, all the liver sections that are done in a non-oncologic setting, perhaps it's education.
I'm curious, Dr. Halle, what's the practice in Canada? Because obviously our colleagues up north tend to follow evidence-based medicine a lot better sometimes than we do.
I don't know about the practice in the entire country. I can tell you where I stand on this. To be quite honest, I'm going to use the word puzzled because I kind of like that. That was a good way to put it. I mean, I'll do it because it's fairly easy to do. If it requires a lot of more effort, I won't push it too much, because my question is, what is it going to change, right? So it's a similar debate that we now have for pancreatic, like how much lymph nodes and how often and to what extent, because at the end of the day, if everybody gets adjuvant based on trials and it doesn't truly change your management, yes, it changes prognosis, but until I think we can show that it will alter what we do with patients, whether, for instance, it's changing the surveillance patterns after completing treatment, I think it's going to be a tough sell until we can say, this is the impact it has on patient management and on patient outcomes beyond prognostication only. Knowing prognostication is only as good as it is, right? There's a lot of limitations with prognosticating patients in general.
There was also a question about other local regional therapies. I know Dr. Maelstrom mentioned obviously the Yttrium-90. What about one of our topics that are near and dear to some of us, with the hepatic artery infusion pump? I know that some of us have had some experience with it in certain centers, and Dr. Schroff actually wrote a nice editorial on the recent WashU Memorial trial. So perhaps we can hear some comments on that. And we only have a minute left, so.
Dr. Schroff, you speak, because I want to hear what you said in your editorial.
I'd have to read my editorial again, but I can tell you that I think my general sense is that I think that it's provocative data, but just like, Dr. Shah very rightfully pointed out that the GAP data is, 2 centers, highly select patient population. That's my argument for HAI. And I think it's the translatability to, community practice and all of that is tough. And then I also kind of pointed out that number one, there was I think a fair amount, like not fair, but there was a liver failure rate that was a little bit high that made me uncomfortable, I guess. And I think that should not be belittled. That's a big deal because we are not talking about HCC, we're talking about cholangio. And yes, their livers are not necessarily that healthy, but they're not usually, child PBC types of cirrhotics that we think about. So that was a little bit jarring to me. And then I also just, the Memorial group did a little bit of looking at the molecular profiling and understanding kind of how maybe some of that might have played into it. And again, it's just a question of how much of this was biology and what exactly was the HAI specifically adding. And so that's why I just mentioned that I think it needs to be in a much larger catchment to be able to understand its applicability.
All right. Well, I think we ran out of time, but I did want to thank everyone here. A big thanks to our panelists. I think, again, congratulations to Stacy and the Cholangiocarcinoma Foundation, and looking forward to seeing everybody at DDW virtually.
Thank you. Take care, you guys.
Have a good night.
Bye. Good night.
Bye now.